When someone has severe skin disease, we know that's inflammation not just on their skin, but occurring throughout their body. We know that leads to more risk for comorbidities. We know that patients with all this inflammation in their body are more at risk for infection in general. So I tell them that, and I say, look at the alternative. You stopped your biologic, and it'll take a few months for your psoriasis to come back. But when that happens, if you go back to where you were, you're at much more risk for COVID-19 infection than you are right now taking your biologic and controlling your disease.
That was Dr. Lawrence Green with commentary on COVID-19 and biologics. Welcome to episode 57 of Dermatology Weekly, where we bring you the latest in dermatology news, followed by a peer-to-peer conversation, or this week, a lecture with clinical research experts in the field of dermatology. I'm the voice of MD Edge Podcasts, Nick Andrews. Don't forget that MD Edge is throwing our full editorial engine behind the COVID-19 pandemic. You can find all of our coverage at mdedge.com. Coming up later, a conversation about biologics in the time of COVID-19. But first, the news. We begin today with approval of emergency use of convalescent plasma for those seriously ill from COVID-19. Since COVID-19 has no known cure and there is no vaccine yet, the FDA has granted clinicians permission to use investigational convalescent plasma under single-use emergency investigational new drug applications, or INDs. This allows the use of specific investigational drug for the treatment of a patient by licensed physicians upon FDA authorization. This does not include the use of convalescent plasma for the prevention of infection. In a statement, the FDA noted that it is possible that convalescent plasma that contains antibodies to the coronavirus might be effective against the infection. Convalescent plasma is promising, but it has not been effective every time it's been studied. The use of convalescent plasma has been studied for other recent outbreaks of respiratory infections, including 2009 swine flu, 2003 SARS, and 2012 MERS. In a case study, Chinese researchers reported that among 5 clinically ill patients with ARDS as a result of COVID-19 who received a convalescent plasma transfusion, viral loads decreased and became negative within 12 days following the transfusion. The researchers also reported that 3 patients were discharged from the hospital after a length of stay that ranged from 51 to 55 days, while 2 patients were in stable condition at 37 days after transfusion and of the time of recording for this podcast, April 1st, 2020. The researchers noted that all of the patients received antiviral agents like interferon during the plasma treatment. The case study was published in JAMA on March 27th. You can find a link to the report in the show notes. And we have more news from the FDA concerning COVID-19 treatment. The administration issued an emergency use authorization allowing for the usage of hydroxychloroquine sulfate and chloroquine phosphate in certain hospitalized patients with COVID-19. These products are currently stored by the Strategic National Stockpile and will be distributed by the SNS to states so that doctors can prescribe the drugs to adolescent and adult patients. According to the emergency use authorization fact sheet, there will be provided to healthcare providers and patients with important information about hydroxychloroquine sulfate and chloroquine phosphate, including the risks of using them to treat COVID-19. You can read the authorization by clicking the link in the podcast notes. And finally today, the Centers for Medicare and Medicaid Services recently announced a wide range of temporary regulatory moves aimed at helping hospitals and health systems handle the surge of patients with COVID-19. Seema Verma is the administrator of CMS. She said the CMS is waiving a wide, unprecedented range of regulatory requirements to equip the American healthcare system with maximum flexibility to deal with an influx of cases. Among the changes is an expansion of the venues in which healthcare systems can provide services. Federal regulations call for hospitals to provide services within their own buildings, raising concerns as to whether there will be enough capacity to handle the anticipated COVID-19 caseload. In a fact sheet, CMS stated that under these temporary new rules, hospitals will be able to transfer patients to outside facilities such as ambulatory surgery centers, inpatient rehabilitation hospitals, hotels, and even dormitories, while still receiving hospital payments under Medicare. As an example, a healthcare system can use a hotel to take care of patients who need less intensive care while using inpatient beds in the physical hospital for COVID-19. Ambulatory surgery centers will have the option to contract with local healthcare systems to provide hospital services or they can enroll and bill as hospitals during the emergency. The surgery centers will be able to perform hospital services such as cancer procedures, trauma surgeries, and other essential surgeries. CMS is also taking actions aimed at expanding the healthcare workforce. For instance, the agency issuing a blanket waiver that allows hospitals to provide benefits to medical staff, including multiple daily meals, laundry service for personal clothing, or childcare services while the staff is at the hospital providing patient care. Teaching hospitals will also receive more flexibility in using residents to provide healthcare services under the virtual direction of a teaching physician, who may be available through audio and or video technology. CMS is also temporarily examining paperwork requirements and allowing greater use of verbal orders. This will allow clinicians to spend more time on direct patient care. On the device and equipment side, Medicare will cover respiratory-related devices and equipment for any medical reason determined by clinicians. This is according to the fact sheet. And on the telehealth side, CMS is expanding the number of services that it will pay for via telehealth by more than 80, including emergency department visits, initial nursing facility and discharge visits, and home visits, which must be provided by a clinician that is allowed to provide telehealth. CMS will allow the use of commonly available interactive apps with audio and video, as well as audio only, which means by phone. The regulatory changes will be in effect for the duration of the public health emergency. And that's it for the news portion of Dermatology Weekly. We'll be right back with Peer to Peer. Welcome back to Dermatology Weekly. It's now time for commentary on biologics in the time of COVID-19. Please welcome Dr. Lawrence Green.
So, as a dermatologist who treats a lot of patients with severe psoriasis with biologics, I have been asked multiple times these last several weeks about what the patient should do who's taking a biologic to control their severe psoriasis. Now, I've received calls from people who take anti-TNF inhibitors all the way to the anti-IL-23s. So, and I think it's important to take it patient by patient. But in general, I have told patients that if they stop their biologic for some time and the psoriasis comes back, so that's severe again, I think that is significantly more risky for getting COVID-19 than if them continuing to take their biologic. That's because when someone has severe skin disease, we know that's inflammation not just on their skin, but occurring throughout their body. We know that leads to more risk for comorbidities. We know that patients with all this inflammation in their body are more at risk for infection in general. So I tell them that, and I say, look at the alternative. You stopped your biologic, and it'll take a few months for your psoriasis to come back. But when that happens, if you go back to where you were, you're at much more risk for COVID-19 infection than you are right now taking your biologic and controlling your disease. Now, they've understood that, so they realize it's important to take their biologic. That said, to go into details about biologics, we really don't know the effect, of course. There's no data on the effect of biologics helping or harming someone with potential COVID-19 infection. There's some information I can give you, some tidbits. I don't know if this will help or hinder your decision-making, but, for example, anti-TNFs may be useful in helping control pneumonia because there's a lot of TNF we know that happens when people have pneumonias. But that said, on the other hand, we know that anti-TNFs are the most general immunosuppressive agent of the biologics. Patients are at increased risk for infection, small amount, very small, but are at increased risks, especially when you compare it to the anti-IL-17s and anti-IL-23s. I think those are much safer and have a less risk for infection than the anti-TNFs. So for patients taking an anti-IL-17 or an anti-IL-23, I think they're safer to continue those while this pandemic is going on. Now, if you have exposure and you know you're at risk, you've been exposed to someone or you're starting to feel feverish, there's no doubt you stopped your biologic for the time being. Stopping a biologic for a few weeks will not bring your psoriasis back to you won't have severe psoriasis, so you know just a few weeks off won't make a difference in the long run. A few months off, like I mentioned, can make a difference. So I think people who take biologics need to take extra precautions in terms of staying away, social distancing, staying at home if you can. There's no doubt about that. Washing your hands, using hand sanitizer, not touching your face. All these things that the CDC recommends. But I recommend stay on your biologic as long as you can, unless you have exposure, you start to feel feverish. Even anti-TNFs at this point, if someone on an anti-TNF wants to switch to an anti-IL-17 or anti-IL-23 because the TNFs are a little more risky, perhaps I think that's a great idea. We can talk about that. But I think practicing the CDC guidelines is very important, and continue taking the biologic is very important. There are also other resources we as dermatologists can go to. The AAD is putting out lots of guidelines. Day after day after day, the AAD has a task force that's just been created to update the membership on COVID-19 infections and how our practices should be adjusting, and that includes information about psoriasis. The National Psoriasis Foundation also has some guidelines released about using biologics for COVID-19 infection. There are lots of resources for us to go to help us get through and help our patients who take biologics in this age of COVID-19 infection, besides the opinion I just gave you.
And that concludes this edition of Dermatology Weekly. Let's get to this week's credits. Dermatology Weekly is produced by MD Edge editors Elizabeth Meshkati and Melissa Sears. Our lecturer this week was Dr. Lawrence Green. The peer-to-peer portion of the show is produced by Melissa Sears and Tyler Mundek. The news is produced by Elizabeth Meshkati. Stories were originally published online at mdedge.com and were written by Doug Brunk, Gregory Twachtman, and Lucas Franke. All MD Edge podcasts are produced by our editor-in-chief, Dr. Ivan Aransky, as well as MD Edge editors Kathy Skarbeck and Mary Ellen Schneider, and multimedia editor Terry Rudd. Dermatology Weekly is produced, edited, engineered by Tyler Mundek. For all of us here at MD Edge, I'm Nick Andrews. You're listening to Dermatology Weekly.